Very good evening, everyone. My name is Abhishek Thakur, and let me take this opportunity to welcome all of you for this wonderful webinar. To start the proceedings of the meeting, I would like to invite and introduce Mr. Sujoy Chakraborty, who is the head of sales and marketing for Expedia Zydus. Let me take up this opportunity to welcome sir. Welcome, and please take up the proceedings for the meeting.
Thank you. Thank you.
Sujay sir, are you there?
Yeah, he's there.
I think Sujay sir lost his connection, I guess. Let me introduce Dr. Samir, who is heading the. Yes, sir. Are you back?
I think his voice is.
Sir, your voice is not audible.
Some connectivity problem is there because the red bar is connected.
Correct. Sir, your voice is not coming to us. So let me take this opportunity to welcome Dr. Samir. Dr. Samir is heading the medical division for Expedia, and he is the person who is responsible for all the medical guidance. He is responsible for the data churning. He is responsible for the medical communication of the division. And let me take up this opportunity to welcome sir. Dr. Samir, welcome to the meeting. And please introduce the speaker and take up the proceedings for the meeting.
Thanks, Abhishek, and a warm welcome to all esteemed delegates. It's a pleasure to invite you all for this webinar on a topic which is not really talked about, yet very important, because not only is diabetes important, but so is its complications. And here today's webinar is going to be focused on a molecule which is addressing the root cause of neuropathy as a complication of diabetes. Without further ado, I would like to introduce Dr. Paneerselvam. Abhishek, you can just confirm if you can see the slide.
Yeah. Yes, sir, it's visible. Right. Only thing is, you can put it on the full screen.
Yes, I hope now it's on the full screen.
Yes. Perfect.
Yeah. So Dr. Paneerselvam actually requires no introduction, but it's my moral responsibility to introduce him. He was formerly Assistant Professor of Diabetology at the Kilpauk Medical College and Government Royapettah Hospitals, Chennai. He is the Managing Trustee of Aruna Diabetes Research Foundation, Chennai. Chairman, Lion KRS Insulin Bank for Juvenile Diabetics. Co-Chairman, Diabetes Association of India, Southern Chapter, Chennai. Co-opted member, RSSDI. Project Coordinator, World Diabetes Foundation and Gestational Diabetes Mellitus Project, Tamil Nadu. He's contributed to original articles on diabetes in international and national journals, and is also the proud recipient of the Diabetes Awareness Initiative Award given by Diabetes India in 2015. So a warm welcome to Dr. Paneerselvam, and I request him to take the academic proceedings forward. Thank you.
Thank you, Dr. Samir, and thanks to Sujay Chakraborty and Abhishek and our local team like Dr. Mr. Balaji. And I'm happy Zydus has taken up this CME on aldose reductase inhibitors, that is epalrestat. The trade name is aldose. So we talk about diabetes in large extent and complication also in large extent. There is one particular drug which is very much useful and in use also, I think, more than 15 years. When this molecule got introduced, I think 15 years before. Anybody knows which year? Epalrestat aldose got introduced when?
So I think it's many years ago. Sujoy, do you have the exact year of launch?
Yeah. I think 15 years before. 15 years before.
Around, history of this brand is almost 16 years. Yeah.
So we are using this molecule since its introduction. Because FDA has not approved it, it doesn't mean that we should not use it in India. Because it is very much useful molecule and safe molecule also. Other molecule of aldose reductase inhibitors only, we had some problem, adverse reactions. But this molecule proved to be safe for more than 15 years. So what sort of benefit it is giving, we are going to see now. And our own clinical practice also, what sort of benefit we had come across in our patient also, you will see at the end. So outline of today's topic is introduction, spectrum, pathogenesis, treatment, evidence, take-home message. And introduction, diabetic peripheral neuropathy is the most common form of neuropathy worldwide. Diabetes also very common, and diabetes complications also very common. Among diabetic complication, even when compared to your CAD and your CKD, etc., neuropathy is more than 50% or 60% of the population. Some sort of neuropathy will be there. More than 50% of the people with diabetes have diabetic peripheral neuropathy, impaired sensation or pain in the feet or hand, slowed digestion of food in the stomach, other nerve problem like your gallbladder dysfunction, gastric dysfunction, urinary bladder dysfunction, and even cardiac autonomic neuropathy, other nerve problem also there. More than 60% of the non-traumatic lower limb amputation in United States occur among people with diabetes. Not only United States, everywhere. Because of neuropathy, they don't feel the sensation. Because of poor control, they develop vasculopathy also. Neuropathy plus vasculopathy will invite non-healing ulcer or infection. So no other go, they have to undergo toe amputation or below knee amputation to save the life. So DPN, diabetic peripheral neuropathy, symptoms and nerve fiber damage, of course, myelinated, alpha and beta, large fiber neuropathy, small fiber neuropathy. So mostly we come across small fiber neuropathy, especially cold sensation and warm sensation. To start with temperature sense only, they don't feel. Then they come to cold sensation, then touch sensation, then the motor neuropathy will go off. Then your cardiac autonomic neuropathy also, now we have dialysis machine that is easily picking up cardiac autonomic neuropathy, and biosthesia meter is easily picking up the vibration perception threshold. Now we have a lot of system to evaluate the complications of diabetes, and your pedography for soul neuropathy or the neuropathy in the soul. So we have not like 20 years before or 25 years before. Pathogenesis, of course, complex, cannot be explained by one mechanism. It results of multiple pathophysiological factors occurring simultaneously. That is, hyperglycemia is predominant. Uncontrolled hyperglycemia, persistently uncontrolled hyperglycemia. Because of persistent hyperglycemia, polyol and myoinositol metabolism, axonal transport, non-enzymatic glycosylation, then ischemia, autoimmunity, compression. These are all rare. Of course, ischemia is there. So euglycemic condition, the polyol pathway, most of the glucose inside the cell is used for energy production. Of course, glucose is the main source of energy, phosphorylated by hexokinase. Small quantity undergo polyol pathway, that is conversion of glucose to sorbitol with the help of aldose reductase enzyme. This is normal physiology in euglycemic condition. In hyperglycemia, aldose reductase activity is overexpressed because of hyperglycemia. Like your renal threshold is overexpressed, and we are using SGLT inhibitor. Likewise, here aldose reductase activity is overexpressed, leading to increased proportion of polyol pathway, and so increased production of sorbitol inside the nervous tissue. So hyperglycemia, excessive glucose uptake in the nervous tissue because it is not insulin dependent. Aldose reductase, sorbitol, decrease in myoinositol concentration in the neural cells, osmotic swelling and damage to the nerves, and oxidative stress, that is glutathione less. So sorbitol causes all these three pathophysiology, leading to diabetic neuropathy. Otherwise, avoiding hyperglycemia is very, very important. So once we diagnose, it is persistently keep diabetes well under control to avoid subsequent complication, not only neural complication, we all know retinal complication as well as renal complications. Aldose reductase inhibitors, epalrestat, an inhibitor of aldose reductase, an enzyme of polyol pathway, prevent the formation of sorbitol from glucose in nervous tissue. See, prevent the formation of sorbitol from glucose in nervous tissue and prevent its complication. Indication and usage approved for diabetic neuropathy in many countries, including India and Japan. Of course, as I had told you earlier, US FDA has not approved this. So hyperglycemia is important determinant of neuropathy. Retrospective study concluded that it is commoner in poorly controlled individuals. Assessment of neuropathy before and after starting diabetic treatment proved improvement in conduction velocity and reversal of resistance to ischemic conduction failure. Acute painful diabetic neuropathy improved after achieving euglycemic control. Otherwise, persistent euglycemia, sometimes acute neuropathy due to acute hyperglycemia also quite common. Sometimes paralysis also occurs. Once you control, the paralysis is becoming all right. In untreated type 2 diabetes, nerve conduction velocity, plasma glucose, and HbA1c correlated well. So polyol ioinositol metabolism, brain and peripheral tissues do not require insulin for glucose uptake. Only the muscle tissue, fat tissue only require glucose. Hence, the cytoplasmic concentration of glucose reflects the degree of glycemia. Once the blood sugar is high, the glucose concentration inside the neural cells also will be high. Aldose reductase, the rate-limiting enzyme of polyol pathway, is present in the peripheral nerves. Increased activity of aldose reductase leads to elevated concentration of sorbitol because of excess glucose and fructose, accompanied by reduction in the myoinositol. So, polyol myoinositol metabolism continued. Excess sorbitol and fructose increased the osmotic damage. Reduced myoinositol results in abnormal phosphoinositide, leading to reduced membranous sodium-potassium ATPase activity. This leads to increased sodium accumulation, causing axonal swelling and axoglial dysfunction. The damage caused by low myoinositol is better documented than the damage caused by the sorbitol and fructose. So sorbitol, fructose, low myoinositol, all put together causes neural damage. And ischemia also occurs. Neuropathy owes its origin to a primary disturbance of the nervous system is possibly an open question. It may result from defective blood supply also. Vascular mechanism plays a major role in asymmetric focal neuropathy. That is especially major nerves. The vasonervosum is affected. Once the vasonervosum develops arteriosclerosis or basement membrane thickening like your retinal arteries, so it goes for ischemia. Substantial evidence exists for a vascular component of mononeuropathy, such as third cranial palsy and proximal muscle weakness or some major muscle weakness. These are all due to vasculopathy of the nerves or vasonervosum angiopathy. Of course, compression also quite common, especially in obese people. Once you release the compression, it gets corrected, but rarely it gets correlated. But of course, once diabetes is not under control, compression neuropathy also is getting worsened. So the treatment for diabetic peripheral neuropathy. So far, we have seen the epidemiology and pathophysiology behind peripheral neuropathy and the role of aldose reductase inhibitors. The treatment, of course, before the aldose reductase inhibitors, we had international guideline like your American Association of Clinical Endocrinology, your American Association of Academy of Neurology, ADA, and your Diabetes Association of Canada, DDC is German, Diabetic German, Association German, and IDF. Everybody, tricyclic antidepressants and SNRI and gabapentinoids, sodium channel blockers, SNRI plus opioid, capsaicin, lidocaine, alpha-lipoic acid. So these are all the various molecules they have tried. And first line treatment, second line treatment, third line treatment, not recommended, not considered. AACE recommends all these molecules as first line treatment and valproate and lacosamide as second line treatment. And so all organizations, they recommended only these things. These are all simple pain reliever. Like your paracetamol, for any fever, you can give paracetamol. Fever will come down unless you correct the root cause of fever. Okay, dengue fever, you have to treat them for dengue. Malaria, you have to treat them for malaria. Similarly, if you don't control diabetes and give only this pain reliever, they give, of course, temporary relief, but controlling diabetes and correcting the pathophysiology behind the neuropathy is very important. So relieve pain, but what about pathological nerve damage? So diabetic neuropathy, a position statement by the American Diabetes Association 2017, pregabalin or duloxetine, various US FDA non-approved agents, including gabapentin, TCA, can be used as second-line treatment. Given the high risk of addiction and other complication, opioid is not recommended. Pregabalin is the most extensively studied drug when compared to other molecules. So integrating pathophysiology of diabetic peripheral neuropathy and drug acting on it. So aldose reductase inhibitors, we discussed the polyol pathway. Polyol pathway is getting increased, it suppresses. So polyol pathway and hexamine pathway is being corrected by the benfotiamine. And lipid control is equally important. Glycemic control is more important. Alpha lipoic acid, reactive oxygen species, and DNA damage is being corrected. AC inhibition and C-peptide also getting corrected by vascular dysfunction, mitochondrial dysfunction. So once you give those drugs, of course, neuropathy can be avoided. Aldose reductase inhibitors, distinct class of drug that interfere with the pathogenesis of diabetic peripheral neuropathy, prevent the formation of sorbitol from glucose in nervous tissue. So this is very important. So prevent the formation of sorbitol from glucose in nervous tissues and so prevents its consequences. Epalrestat is an ARI approved in Japan, India for diabetic neuropathy. So dosage is 50 milligram 3 times a day before each meal. OD formulation like 150 milligram once a day. Minimum recommended duration for epalrestat is 12 weeks, that is 4 months or 3 months before considering alternate treatment. Not recommended in lactating mother. Patients should be instructed about the yellow, brown or red discoloration of urine while on epalrestat. If they take more water or liquid preparations like buttermilk, etc., this is also can be avoided. But during summer, they take less water, the red discoloration is much higher. But they should not worry about it. Doctors also may not worry about it. But if they take more water, it will get cleared. Once the metabolism cleared, so again urine will be normal. Clinical evidences, clinical evidence 1, the epalrestat in diabetic peripheral neuropathy for 24 weeks. 45 type 2 diabetic patient, diabetic peripheral neuropathy were given epalrestat 150 milligram for 24 weeks. Patients were evaluated for spontaneous pain, numbness, and hyposthesia at 0 week, that is at the time of starting, 12th week and 24th week. Vibration sensation was also measured by tuning fork. So at 0 week, symptom disappearance rate was 0 to start with. 12th week and 24th week, spontaneous pain in upper extremities is very much regressed. So much percentage of the people, the spontaneous regression after 24 weeks regressed. Similarly, spontaneous pain in lower extremity also, so much percentage of the patient disappeared. So numbness, 12 weeks and 24 weeks when compared to initiation, numbness also very much improved in the 80% of the people, more than 80% of the people. Similarly, hypoesthesia also. Spontaneous pain in lower limb, numbness and hypoesthesia significantly improved after epalrestat treatment. Epalrestat in diabetic peripheral 24 weeks, vibration perception test, baseline 12 weeks, 24 weeks. Here they say from 7 to 8.5. But in our clinical practice, we come across a huge difference in the vibration perception test as well as temperature sense also. Vibration sense improved significantly by 24 weeks of epalrestat therapy. So the second point is 12 weeks epalrestat DPN. Efficacy of epalrestat evaluated in 196 diabetic peripheral neuropathy patient by a double-blind study with the placebo, that is P group and your study group. Spontaneous pain in upper and lower extremity and sensory disorders were assessed under millimeter analog scale. Motor nerve conduction velocity was measured at median and peroneal nerves. Sensory nerve conduction velocity was also examined at the median nerve. So spontaneous pain in upper extremity when compared to placebo group, your study group, the disappearance of the rate is much higher. Similarly, spontaneous pain in the lower limb also, the spontaneous symptom disappearance rate is when comparatively higher in the epalrestat group when compared to placebo group. 12-week epalrestat from diabetic peripheral neuropathy, nerve conduction, that is group AP, and this is peroneal nerve, median conduction velocity, and the median nerve mean conduction velocity, median nerve sensory conduction velocity. So total number of patients for each group, and your conduction velocity before they start treatment, after they start treatment. So 38 becoming 39, 45 becoming 49, 45 becoming 47. So the conduction velocity is getting improved. Epalrestat improved the motor nerve conduction in the median nerve in various study groups. Long-term study epalrestat in DPN, that is aldose reductase diabetes complication trial. DPN patient, the median motor nerve conduction velocity more than 40 milliseconds and HbA1c less than 9 were enrolled to 150 milligram of epalrestat and control group 305 patients, here 289 patients. Primary endpoint change from baseline in median or median motor nerve conduction velocity. Secondary endpoint, minimum F-wave latency of the median motor nerve and vibration perception threshold, follow up 3 years. So all patients, so median nerve conduction velocity in epalrestat group comparatively higher when compared to control group. Similarly, A1C 7 to 9. So epalrestat group comparatively higher. Less than 7, epalrestat group much higher. So when compared to all patients and between 7 and 9, so less than 7, once the blood sugar is under control, the benefit of epalrestat is much better. Much better. And again, A1C more than 9, benefit is there when compared to control, but it is not that much. It is not that much. So primarily we have to keep diabetes well under control. By keeping A1C 9, no point in treating them with epalrestat. Even any other complication. They develop renal failure, they undergo transplant. After transplant, again, if they don't control diabetes for another 3 or 4 years, again they land up with the transplant kidney is getting failed. They go for dialysis. They had infarction, undergoing bypass. After another 4 or 5 years, they are not maintaining the cholesterol, sugar well. Again, they land up with the reinfarction. They go for. Similarly, even if you use epalrestat, if you don't keep the blood sugar well under control, A1C less than 7, the benefit is much better when compared to A1C more than 9. So epalrestat preserved nerve conduction up to 3 years of therapy in diabetic peripheral neuropathy patients. Again, ADC study, subjective symptoms and symptom score changes. So when compared to control, the symptoms are very much regress in the epalrestat group. A1C less than 7, the symptoms very much low. Whereas A1C more than 7, not that much. So your control group as well as drug group almost same one. Less than 7 or less than 9 to 7, much better, much better. But here less than 7, much more better. Epalrestat provided symptomatic benefit up to 3 years therapy in diabetic peripheral neuropathy patients. ADC study results 1 year, second year, and third year. Median nerve conduction velocity, control group and epalrestat group. So baseline 53, in control group minus 0.49, here plus 0.29 the conduction velocity. Second year plus 0.28. Similarly, your median wave velocity, the multivariate epidemiological analysis, long-term clinical effect of epalrestat and aldose reductase inhibitors on progression of diabetic neuropathy and other microvascular complications, multivariate epidemiological analysis based on the patient's background factors and the severity of diabetic neuropathy. The subjects in the current study were selected from ADCT, that is diabetes complication trial, that is aldose reductase inhibitors trial, for whom data for major patient characteristic and neurological function test at the end of the study, retinal findings and evaluation of nephropathy were available. So multiple logistic regression analysis of efficacy of epalrestat and effect of patient's background on progression of diabetic retinopathy as well as nephropathy. Conclusion, epalrestat prevented progression of diabetic neuropathy and retinopathy plus nephropathy also. This we come across in our clinical practice also. The effect on diabetic retinopathy and nephropathy may have occurred indirectly because of prevention of progression of diabetic neuropathy, in addition to inhibitory effect of epalrestat on aldose reductase. It inhibits aldose reductase enzyme everywhere, not only in the peripheral nerves, in the retinal nerves also, in other places also. Because I used to tell in the patient's meeting, blood goes everywhere, excess sugar also will go everywhere. Every organ is getting affected. In some of the organ, patients are developing symptoms. In some of the organs, by investigation, we diagnose. But all the organs are getting affected by the excess glucose. Epalrestat and aldose reductase inhibitor in diabetic neuropathy, an Indian prospective study. This is 12 to 24 weeks. Subject 2000 diabetic peripheral neuropathy patient having median nerve conduction velocity 40 with the mean A1C 8.4. 90% were type 2 diabetic, 10% were type 1 diabetic, 150 milligram of epalrestat given. So spontaneous pain of upper extremities before administration. So this red color, blue color, red color, and a light yellow color, severe, moderate, mild, and no symptoms. So this much percentage doesn't have any symptom. 3 months later, 6 months later, the severe spontaneous pain is much less. Similarly, the red color bar also less, and yellow color bar also much less. Spontaneous pain is the lower extremity, upper extremity as well as lower extremity. Here also after 6 months, the blue color bar is very much less. So numbness also, before they start the treatment, this much amount of percentage. After 6 months, the blue is getting regressed. Similarly, coldness, hyposthesia. So epalrestat reduce spontaneous pain in the both upper and lower extremities. Epalrestat reduce numbness, coldness, and hyposthesia also. Nerve function test, conduction velocity, sensory nerve conduction velocity, and vibration. Before administration, 3 months later, before administration, 3 months later, before administration, 3 months later. So epalrestat improved nerve conduction and vibration sense because this molecule is in use in our country for 15 years. We definitely come across similar benefit, not only in studies, similar benefit is in 2008. But unfortunately, this molecule is not getting picked up among diabetologists, endocrinologists, etc. But this is very much useful molecule. So we need not expect to use, for example, vildagliptin or glycoside. The FDA has not endorsed it, but we are all using globally. And our alpha glucosidase inhibitors. Sixth point is effect of epalrestat on AGE. Advanced glycation end product play an important role in diabetic peripheral neuropathy. Serum N-carboxymethyl lysine, CML, is AGE in DM. In a study of 38 type 2 diabetic patients with DPN were treated with epalrestat 150. CML levels in patients were compared with the 36 DPN patients not on epalrestat. Motor and sensory nerve conduction velocity in lower limb nerve were also compared. So effect of epalrestat on advanced glycation end product. Advanced glycation end product is change in your CML level is less after 1 year. Epalrestat can significantly reduce AGE production in the DPN patients, so that only other complications like your nephropathy, retinopathy also coming improved because of this mechanism. Effect of epalrestat on nerve conduction velocity. Change in median conduction velocity and change in sensory conduction velocity. Epalrestat prevented further deterioration of nerve conduction in the lower limb in diabetic peripheral neuropathy. Long-term effect of epalrestat on cardiac autonomic neuropathy. 22 DPN patients treated with epalrestat for 3 years. Change in CV-RR interval during rest and QTC interval were compared with the age-matched 43 control with DM, not treated with epalrestat. So in the epalrestat group, the cardiac autonomic neuropathy improvement is much better when compared to control group. In our real case evidence also, I will show how the cardiac autonomic neuropathy also getting improved in our clinical practice. Epalrestat and gastroparesis. The study evaluated electrogastrogram, electrocardiogram, electroencephalogram, electrogastrogram and autonomic nervous activity in 15 healthy volunteers and in 15 diabetic peripheral neuropathy patients before and after epalrestat therapy. The electrogastrogram peak amplitude 3 CPM cycle per minute recorded before and after epalrestat in diabetes mellitus group. So this is normal group, diabetes with epalrestat group, and DM not treated group. So diabetes with epalrestat group, the peak power amplitude is much better when compared to not treated group. Epalrestat can have beneficial effect on the diabetic gastroparesis. Otherwise, wherever the polyol pathway is predominantly acting, of course, in all nervous tissue, whether it is autonomic nerve or sensory nerve or motor nerve, once you control diabetes, correct the polyol pathway, reduce the sorbitol content in the nerves, automatically the nerve function will get improved. Along with that, if you give methylcobalamin or alpha-lipoic acid, they improve the further nerve function. Combining epalrestat with other drugs. As onset of effect of epalrestat for patients presenting with the painful diabetic peripheral neuropathy, you can combine with the pregabalin. You can combine with the methylcobalamin also, can incremental neuronal and symptomatic benefit of the diabetic peripheral neuropathy. So this is the recent article, 2024 article. Epalrestat, an aldose reductase inhibitor, easily absorbed into neural tissues and inhibit aldose reductase with the minimal adverse effect. See, inhibit neural tissues with a minimal adverse effect. This drug can inhibit potential abnormalities in polyol pathway and mitigate metabolic disorders. Preclinical and preliminary clinical studies have revealed that ARI can improve nerve conduction velocity also. Although epalrestat has not received regulatory approval for marketing in the United States, it has been approved in the treatment of diabetic peripheral neuropathy in several Asian countries, including China and Japan. So along with the pregabalin, so your pain is very much less and maintained. So sleep quantity or quality also getting improved. Weekly mean pain score on 11-point numerical pain rating scale is 146 dp patient treated with pregabalin when compared to placebo. Methylcobalamin and epalrestat, again, assessment of final studies. So methylcobalamin and epalrestat in diabetic peripheral neuropathy, pain intensity, FDC of epalrestat and methylcobalamin much less before baseline, and week 4 and week 8 and week 12. So your pain intensity is very much less when compared to epalrestat group. Similarly, muscle strength also getting improved in the FDC combination of epalrestat and methylcobalamin. The tendon reflex also getting improved. Methylcobalamin and epalrestat is more effective in reducing pain, increasing the muscle strength, and improving the tendon reflexes versus epalrestat alone. So that few companies are combining epalrestat with methylcobalamin plus pregabalin also. Methylcobalamin and epalrestat in the Indian study, global evaluation therapy by the investigators, FDC of epalrestat plus methylcobalamin and epalrestat. So here the combination is global evaluation by the investigator, that the percentage of patients improve good and very good. So methylcobalamin and epalrestat was perceived to be better when compared to epalrestat alone. Few real case evidences. So I will show some of my real case evidences. This is pedography of the feet. We have to make the patient to walk on the electronic platform. Electronic platform has got transducer. If you walk on that, if sensory nerves are intact, the weight impression or the body weight impression is getting picked up by these transducers. If the sensation is intact to bear the weight of the patient, it should go up to 30 in the weight bearing area, forefoot, great toe, as well as sole, your heel. So these are all non-weight bearing area. Non-weight bearing area, the maximum number is 10. In weight bearing area, the maximum number is 30. Instead of 30, left great toe 42, right forefoot 34. Once you control and maintain 2007, 2008, 42 becoming 21, Lalita patient, and 34 becoming 22. Similarly, another patient, 2009, instead of 30, it was 119 and 104. Once you control and maintain the control, give some neurovitamins, plus or minus epalrestat, 71 or 66. So your ankle brachial index, if it is less than 0.9, there is some amount of deficiency in the circulation of the lower limb or the feet. Once you control and maintain the control, right side as well as left side, 0.9, then 1.18, coming to more than 0.9. Similarly, vibration perception test must be less than 15. For this particular patient in 2006, it was 45, right side, left side 44 by your biopsy meter. So once you control and maintain the control, 33 and 11, less than 15. So vibration perception test is neurological or microvascular complication, where ankle brachial index is macrovascular complication. Both are getting reverted. So that I used to tell in our colleagues meeting, diabetes also reversible and its complications also reversible, provided if you approach properly. And diabetes is preventable also. You can prevent diabetes, you can identify diabetes very early and revert it back to normal. And even if you clinically diagnose diabetes, maintain the good control. Even if they develop complication, identify the complication. To identify such complication 20, 30 years before, we didn't have any mechanism. Simple tuning fork, they may say less, they may say no, or they are feeling equally good. But here we can measure with the help of biopsy meter, the vibration perception test. So we can reduce it also by keeping diabetes well under control. This is heart sensation, temperature sense. They are supposed to feel at 41 degrees Celsius. If they feel at 45 or 48, so if they walk on the terrace, the hot surface, they may not feel the hot. They may feel, but not to the level of normal level. So wherever they walk on the hot surface, they may not feel the hot sensation. Once the 48 is there, 2013, once you control and maintain the control, plus or minus your epalrestat, so 2014 becoming normal. So this patient developed careless because of severe sensory neuropathy. Once you maintain the control and give vitamin plus epalrestat, so it is totally getting reverted. Persistent good control, reverse neuropathy, and formed careless. See, both the careless, he was not in a position to walk properly, had a severe pain, becoming normal. This is again due to sensory neuropathy, the new Chapel bite, and he developed non-healing ulcer for 3 years, not getting healed because of poor control state. Once you control and maintain the control, so getting healed. So the discoloration also, black in discolor, skin pigmentation. Once you maintain the good control, the black color also is getting disappeared. So motor neuropathy, what we have seen so far is sensory neuropathy of the sole, sensory neuropathy of the dorsum of the feet. Motor neuropathy, unable to hold the chapel. To hold the chapel while they are walking, the muscles in the sole should act and hold the chapel. If motor neuropathy occurs due to uncontrolled diabetes, they are not in a position to hold the chapel because the blood sugar was persistently high. See, 212, 276, 420, 420, and A1C also 7.9. And duration of diabetes also very much high, 91. I have seen the patient in 2012. Once you maintain the control, PP blood sugar always less than 160, fasting less than 110, A1C 6.3, could able to hold the chapel. Even if they develop motor neuropathy of the sole or intrinsic muscles, if you control well and give your aldose reductase, give it as epalrestat, the motor neuropathy also getting reverted. 1 minute. Hello? Meeting patient. So could able to hold the chapel. Cardiac autonomic neuropathy. So we have one machine called Diansys. This Diansys will pick up cardiac autonomic neuropathy. This green color is parasympathetic activity. This is sympathetic activity. Once they develop cardiac autonomic neuropathy, parasympathetic denervation occurs, sympathetic overactivity occurs. So the percentage must be less than 25, or the curve must be both parasympathetic and sympathetic should get correlated around 0 level or less than 25. For this particular patient, the cardiac autonomic neuropathy percentages instead of less than 25, it was 57% in 2011. By keeping diabetes well under control and giving neurovitamins plus epalrestat, 2011, 2012, 18%. So the curve has come down here to closer to 0. So less than 25, 18%. So the A1C was earlier 8.1, A1C now 5.1. So A1C 5.1, nowadays people will not develop hyperglycemia. Earlier, only to achieve A1C 7 with the help of insulin, sulfonylurea, and metformin up to 2000, 2003, we had repeated hypoglycemia because of either sulfonylurea or insulin. Now, along with metformin, we have a lot of non-sulfonylurea molecules to keep diabetes well under control without causing hyperglycemia, or physiological level of glycemia is achievable now with the non-sulfonylurea molecules, by which even if they develop complication, the complications are getting reverted. So you again were cardiac autonomic neuropathy, CAN. 2007, this patient had instead of 25, 75%. Then came down to 73, 61, 35. Otherwise, in 75, they may not feel the pain of the heart attack. Silent heart attack, they may feel tiredness, weakness, breathlessness. And sometimes they subjected for major surgery because of cardiac autonomic neuropathy during surgical anesthesia. They may develop cardiac failure or cardiac arrest or respiratory failure. We cannot wean them from the ventilator. So to that level, the 75% of cardiac autonomopathy will give problem. Once you maintain good control and give neurovitamins plus epalrestat, 75 becoming 35. Asymmetric sweating. Because of uncontrolled state, this patient had upper body sweating, asymmetric sweating, a form of autonomic dysfunction of diabetes. Once you keep diabetes well under control, so A1C 6.8, no upper body sweating, asymmetric sweating since 2 years. This patient also cold profuse sweating. Again, A1C 12.7, 8.3, 8.3, repeatedly high. Cold profuse sweating, wetting her blouse always. But once A1C 7, 95 and 117, sweating stopped after good control of diabetes. This is all, again, 12 years before. Not only your autonomic neuropathy, motor neuropathy, as well as sensory neuropathy, retinopathy also, mild non-proliferative diabetic retinopathy. Still, many of the ophthalmologists are under the impression, even neuropathy also, some of our colleagues are under the impression, neuropathy is a degenerative condition. Once they develop neuropathy, it may not get reverted back to normal. This is the impression, unfortunately, many of our even senior colleagues are having. But it is not so. They are all, I am in practice from 82. 82 to 2005, this was the struggle we had. Diabetes also progressive, complications also progressive. These are all the statement up to 2000, 2005. From 2005 to till today, we are in a position to prevent diabetes. We are in a position to diagnose diabetes very early, revert it back to normal, and we have better mechanism of monitoring like self-glucose monitoring and continuous glucose monitoring, maintain the blood sugar, maintain the A1C, by which avoid complications. Even if they enter into complications, now we have vibration perception test, urine for microalbumin, and your pedography, fundus photography. These are all the investigations which are diagnosing neuropathy very early or complications very early. Once you diagnose complications early, by again keeping well under control and giving drugs like alpha or aldose reductase inhibitors, you can revert them back to normal also. Otherwise, we should not allow the diabetic to enter into complication and make them to struggle and suffer, even though they undergo treatment, even though we treat them. So this mild NPDR, 2017, 2019, normal. Sundaramurthy. So earlier also, Sundaramurthy in 2017. Sundaramurthy in 2019, normal fundus. Similarly, Shanmugam, 2017, mild NPDR. Shanmugam, 2018, normal fundus. So primarily the good control only. Similarly, Jayanti, mild NPDR in 2018, 2019, normal fundus. So we have to identify the problem very early. So the message is, in 2011, the A1C was 7. Now persistently, A1C is always less than 6.5. This is very much possible from 2005 onwards by modern treatment and modern monitoring mechanism. This patient also had diabetes in 2002 with A1C 10.8 at the time of diagnosis. Now always the A1C is around 6.5 or less than 7 only. This patient had uncontrolled diabetes for more than 10 years, 2001 to 2011. Had a complication, underwent bypass, kidney transplant, retinopathy, as well as non-healing ulcer, for which only he came here. We would have to pull down and maintain the A1C around 6.5. This is very much possible by current day treatment. We need not always maintain the A1C always at less than, more than 8 or 9. And they are under the impression they are on regular treatment. We are under the impression we are treating them effectively with all latest guideline and latest article references. But unfortunately, I could say 70 to 80% of the treated diabetics are wandering the clinics like this only, wandering the hospitals. It is up to the consultants to pick up such cases and pull down the A1C and maintain the A1C like this. So by which this patient had non-healing ulcer for more than 6 months. This is glycation of proteins. So you can measure HbA1c, you can measure blood sugar. Once the glycation of protein occurs, you cannot measure in day-to-day clinical practice. Once glycation of tissue protein occurred, non-healing ulcer, your kidney damage, retinal damage, all damage will happen. So once you maintain the control, the tissue damage is regressing, the wound is getting healed, not totally getting healed. Otherwise, we should not allow the patient to go to that extent. Even, unfortunately, some of them are going, but we will be able to bring back to normal. So the take-home message is, diabetic peripheral neuropathy is highly prevalent and disabling condition associated with significant healthcare cost. Currently, management mainly revolves around good glycemic control and symptomatic treatment. And earlier, up to 2000, 2003, good glycemic control was also not possible, and we had only symptomatic treatment. Now, for the past 15 years or 20 years, we have maintaining good control mechanism well, and we have better molecules to treat diabetics. In addition to symptomatic relief, we have aldose reductase inhibitors, definitely proved molecule, safe molecule. Therapeutic options targeting root cause underlying pathophysiology have not been sufficiently utilized. Even now, it is not utilized. Polyol pathway plays an important role in neurological damage, so that only in many of my patients, which I have shown to you, many of them used epalrestat. So that only many of them got reverted back to normal, in addition to our vitamins. Epalrestat can inhibit polyol pathway and can prevent further neurological damage in the diabetic peripheral neuropathy. And further, we have to maintain the normal glycemia. Use of epalrestat with the traditional anti-diabetic peripheral neuropathy like pregabalin can provide early symptomatic benefit and preservation of nerve function by giving alpha-lipoic acid or methylcobalamin, etc. Addition of methylcobalamin or alpha-lipoic acid to epalrestat can give incremental neuronal and symptomatic benefit in the diabetic peripheral neuropathy. So this is the take-home message. So whatever doubt you have, you can interact for another 15 minutes. So this is about epalrestat and pathophysiology behind diabetic peripheral neuropathy and how to correct it. Thank you.
Thank you, Dr. Paneerselvam. I think that was an exhaustive talk, first on the concept of the molecule and then your real-world evidence. It's, ultimately, it's how the molecule fares in clinical practice is more
important,
equally important. So we do have few questions from the audience, so I'll just take them one by one. Okay. So the first question is, although there is published literature, but in the Indian scenario, how frequent is the prevalence of neuropathy associated with diabetes and without diabetes?
So neuropathy in general population without diabetes are also quite common. So vitamin B12 deficiency, smoking, alcohol, even anemia, these are all the other causes, sometimes autoimmune. But when compared to all other causes, diabetes predominantly more, even when compared to nutritional. Otherwise, diabetes neuropathy is known. Once patient has diabetes, we have to correct diabetes first. Despite correcting diabetes and maintaining, still the neuropathy symptoms are there. Then you can think about smoking, you can think about alcohol, other nutritional, etc., etc. But here, among diabetics, neuropathic symptoms are quite prevalent, There are differential diagnoses. Non-diabetic population also has neuropathy. When compared to, of course, 100 non-diabetic population, about 100 non-diabetic population, hardly 5 to 10% will have neuropathy. Among diabetic population, minimum 40 to maximum 60% will have neuropathy. That difference we all should understand.
Great. So the second question is, the doctor has a query that usually at the diagnosis of diabetes, 50% of the beta cells are destroyed. So in a case of diabetes, how early does neuropathy set in when it may not be clinically manifest, but it would still be there in the nerves? So how early would it be after a diagnosis of diabetes?
Yeah, again, this 50% beta cell loss is UKPDS concept. Even if you take that concept even now, because UKPDS use metformin, along with the metformin, they use sulfonylurea as well as insulin. 1977, they started the study, and 1997, they ended the study 20 years after. Then 98, it got published. So these two molecules or three molecules, along with the diet and exercise, were not effectively controlling diabetes. Now, after UKPDS, we have alpha-glucosidase inhibitors, pioglitazone, gliptins, gliflozins, now imiglivin recently, GLP-1 receptor analog. They are all non-sulfonylurea molecules without further spoiling the beta cell, effectively controlling diabetes along with metformin as well as insulin therapy. Otherwise, the so-called 50% loss is yesteryear theory. Even if we are under the impression only 50% is there, with the help of 50%, the remaining life can be achieved. Remaining life can be rotated. Otherwise, you need not spoil the remaining 50%. So what they said, at the rate of 4 to 5% per annum, another 10 to 14 years, they lose all beta cell function. They have to land up with the insulin requirement. If they don't take insulin properly and maintain good control, they land up with all complications. These are all, of course, before the birth of Christ, after the birth of Christ. Similarly, before UKPDS, after UKPDS. After UKPDS, the monitoring system, understanding available molecules, sharing the knowledge globally is totally different. We can keep 50% beta cell loss as finding, but you cannot apply nowadays in clinical practice. You can retrieve the beta cell function. You can regenerate the beta cell. Similarly, once they develop neuropathy also, so sometimes asymptomatic hyperglycemia, asymptomatic neuropathy also there. Neuropathy sets in before you diagnose diabetes itself. Similarly, nephropathy sets in before you diagnose retinopathy also. So we sometimes diagnose diabetes while we are diagnosing complications, That is the problem in the management. So that we keep on telling to the professionals, keep on telling to the government, early screening for diabetes, early screening for complication is very, very important. Unfortunately, neither the patient nor the public nor the health planners, administrators understand this. So asymptomatic complications, asymptomatic hyperglycemia, but while screening, if you come across, definitely this mild diabetic retinopathy, moderate proliferative diabetic retinopathy, they are all asymptomatic. On screening only we could able to pick up. Similarly, your pedography, on screening only we could able to pick up. Hot and cold sensation test, on screening only we could able to pick up. So the heart sensation 49, once you control diabetes becoming 40. So that it is better to subject your patient. Unfortunately, 90% of the patients are entering into the clinic with some number. Many of our colleagues are simply looking at the number, writing some prescription. So 90% of the patients are not getting evaluated for complications. That is the major drawback. So even if they lose beta cell function, even if they enter into complications, now it is very much possible to retrieve the beta cell function, or further loss of beta cell function can be avoided. And even if they enter into complications, you can revert back to normal side, or you can arrest the complications.
Okay. So one interesting question is, how do you rate 50 milligram thrice daily versus 150 milligram once daily with
that is your metformin. Metformin instant release and sustained release. So likewise, this 50 milligram triple the time is very much difficult, because already they are taking for diabetes itself minimum 2 to maximum 3 items. For hypertension, for cholesterol, for CAD, and if they develop nephropathy, etc., etc. So better to go for 150 milligram OD. For you also, for company also, I think 150 milligram OD is moving faster when compared to 50 milligram.
Okay. Another interesting question with respect to the early diagnosis, as the question doctor has a question that as detection of neuropathy is primarily clinical, are there any surrogate markers which can help in early diagnosis of neuropathy in diabetic patients?
There is no surrogate marker. Only thing is routine investigation only. Patients sometimes they come with some symptoms, burning feet or numb feet. They come with some symptoms. Even if you don't have biosymmeter or hot and cold perception test, all this modern investigation, at least we should have some tuning fork. And many of our colleagues are sitting in the AC room, and definitely the hot and cold sensation that they feel. So tuning fork text, same tuning fork for cold sensation also we can use. But it will give some quantitative information. But qualitative information, better to evaluate them for, there is no marker, specific marker.
The next question is epalrestat, as the data was projected, was shown to be working well with pregabalin or methylcobalamin. So even the data was projected in with respect to benefit in gastroparesis. So can epalrestat, in addition to pregabalin or methylcobalamin, be combined? Is there a scope of combining epalrestat with any other agent which can help in either diabetes, neuropathy, or other complication of diabetes like gastroparesis?
Yeah, already methylcobalamin is getting combined with epalrestat, and your pregabalin also getting combined with epalrestat. Already the combinations are available. And the pill burden is less. Suppose if they have severe pain, similarly neuropathy, and in addition to controlling diabetes, give pregabalin plus your epalrestat combination. Once the pain sensation lost, you can stop your pregabalin component. Once the nerve function is improved well, you can even stop epalrestat also for after 2 months to 3 months of therapy. Suppose neuropathy symptom is still there, or on investigation, still it is not getting improved, you can continue, because some studies continued epalrestat even for 3 years. But in my clinical practice, I use minimum 2 months or 8 weeks to maximum 6 months only. And I could say earlier only, before epalrestat, I had come across yearly 4 or 5 cases of total neuropathy. Whatever control we give, whatever neurovitamins we give, they don't develop improvement. But now we don't come across.
Because so the last question, yeah. Yes, sir.
Yeah, but quality of control now improved. See, self-monitoring have now improved. And epalrestat is helping such patients.
So the last question which was there was also answered by you, that in clinical practice, how long can you use epalrestat?
Yeah. See, in my practice, I use minimum 4 weeks to maximum 6 months only I use, not for 3 years.
Okay, right.
Not
so
required
I think,
also, I think.
Right. So I think there are many questions, but many of them are repetitive. But more importantly, we've got a lot of feedback that your session was pretty exhaustive, and the clinical cases that you projected were very, very useful. So before we close, can we have the final take-home messages from your end for the attending delegates?
Yeah. So our message is, we keep on talking about diabetes globally also. IDF also, World Diabetes Day from 1991, almost more than 23 years, global awareness on diabetes is being created. Unfortunately, with these 30 years or 33 years, the percentage of the quantum of diabetes globally keep on increasing only. So we have to reduce the quantum of diabetics by sensitizing the entire population of any country. And we have to subject the population for early diagnosis, prevention, maintaining the good control. So by doing so, we can avoid complications. Even if they land up with the complications can be identified early by modern practice, as you have seen now. Because as you all know, I have told you from 82 to 2002, such investigations were not available. Such molecules were not available. No such investigation. These are all simple investigation, not like your MRI or CT scan or PET scan costing about 8 crore, 10 crore, etc., etc. These are all around minimum 30,000 rupees to maximum 3 lakhs rupees only. These investigations are, equipments are all. So by using this equipment, identify the complications early. Don't expect the patient to give symptoms. Ask the patient to undergo annual evaluation of complications. If you identify complications early, good control again, revert them back to normal. And epalrestat helps to revert the complications very early, very early. So ultimate aim is we should not allow the patient to enter into complication, like your leprosy. Leprosy, they have not diagnosed early and treated properly 20-25 years before. Many landed with crippling complication and disfiguring complications. Now we diagnose leprosy early, intensify the treatment by which the crippling and disfiguring complications are not there. Similarly, future quantum of diabetes should come down and the quantum of complication also should come down, or we need complication-free diabetics. Even if they develop diabetes, they should not develop complications. Complications are not occurring like road traffic accident or fire accident or acute abdomen, acute appendicitis. Complications are occurring after 3 to 4 years of uncontrolled state only. Patient may wander the hospital with uncontrolled state. The treating doctor should not make the patient to wander the hospital in uncontrolled state. That is the message.
Sure. Thank you. So I think it was a great learning for all of us. And thank you very much for a very comprehensive talk. And it was a really interactive session. And the questions posted by the audience were very well addressed. So thank you again. And thank you all our attending doctors for sparing their valuable time, that too on a long weekend evening and away from the family time that you would typically have. And I'm sure today's webinar learnings will go a long way in helping us in treating our patients better and better. And I just would like to close by saying wish you all a very happy Holi in advance, and may God bless each one of us. Thank you.
Thank you for Zydus for giving me this platform. Thank you,
Thank you. Thank you, sir. Thank you so much.
Thank you.
Thank you,
Recording
sir.
stopped.
Thank you. Sir, it was attended